So we are going to know how to evaluate scapular fractures, how to classify them, and to know about the associated morbidity, because a lot of them are associated with morbidity, and about 5% of all scapular fractures have associated mortality. Okay, so out of all the different classifications, there are a lot of them. You are supposed to know the classifications of the scapula and glenoid fractures, the indications of surgical management, and to identify the operative approaches. So, incidence, it's about 3 to 5% of all fractures of the shoulder girdle, and less than 1% of all the broken bones. It's associated with high energy trauma, and 90% of these have associated injuries. Okay, so mechanism wise, it can be a direct blow. In a direct blow, there is an associated injury of the chest as well as of the shoulder, rest of the shoulder girdle as well. And the chances of, say, even a single rib fracture or multiple rib fractures, chest injuries, hemothorax, pneumothorax are about 70 to 100%. And the other mechanism is an indirect mechanism where there's a traction injury to one of the processes of the scapula, like the acromial process or the coracoid process. It could be an avulsion fracture, say, of the coracoid process. There could be an avulsion fracture, or there could be an avulsion fracture of the triceps, which originates from the inferior border of the or the lateral border of the scapula, inferior to the glenoid. And impaction of the humeral head leading to a glenoid rim fracture. Of course, most of these are taken care of by our arthroscopy colleagues, where they can either elevate or augment them with the help of a Latarjet procedure. Okay, so in the associated fractures, 44% of fractures of scapular fractures are associated with a rib fracture. 25% or 26% are associated with a clavicle fracture, and the most commonest long bone associated with or extremity long bone as such would be the humerus. Even though clavicle is a long bone, the extremity long bone would be a humerus, which is about 12%. Okay, now coming to the associated injuries, here about 20% of them either have a cerebral contusion or other neurological injuries. Even the spinal cord injuries or a brachial plexus injury is associated with with scapular fractures. The next most common would be a pneumothorax or a hemothorax. Of course, with the cerebral contusion, the chances of mortality is also very high. Whereas the second most commonest cause would be a pneumothorax, a hemothorax, or a pulmonary contusion, which make about 15 to 20%. Okay, then we have the ruptured spleen, renal contusion, subdural injuries, but all of these are very less commonly seen individually, but as a complex of polytrauma. Okay, and you see about 2% of the injuries, scapular fractures, are associated with death as well. Okay, so it is indirectly showing us that it's a very high velocity trauma or high energy trauma, which leads to scapular direct fractures. Okay, now in the clinical examination, we need to look at the skin. There could be contusion, hematomas of the surrounding area. There could be puckering of the skin. Apart from the local skin inspection, we need to look at the cervical spine and the thorax. We need to auscultate to check for the chest function, the neurological examination of the spine as well as of the associated upper limb, vascular examination of the associated upper limb, and associated injuries like rib fractures, hemothorax, pneumothorax, pulmonary contusion, head trauma, facial trauma, as well as spine trauma have to be assessed. Okay. Now, radiology wise, we have three workhorse views for the scapula. We have the true AP view of the shoulder. That is the AP view in the scapular plane. That's about 30 degree. The body is a 30-degree bent anteriorly, so that the plane of the scapula, the glenohumeral joint, is seen in profile. Then the other view is the scapular Y view and the axillary view, which are helpful to get a better idea of the scapula. But in cases of comminution in the scapula, all these views are also not enough to understand the anatomy. And that's why CT scan and CT scans with 3D reconstructions really help us out over here. Because since most of these patients do have a chest injury, they may require a chest CT. And at the same time, it's easier to get a CT scan of the chest done. Okay. Uh, so talking about a little bit about the anatomy. So we have the articular process as well as the process of the scapula. We have two processes, that is the acromial process as well as the coracoid process. Now we know that the glenoid fossa articulates with the humeral head, and that the glenoid fossa is retroverted about 20 degrees in comparison to the plane of the spine of the scapula. Okay, then we know that there are ligaments which attach the scapula to the clavicle and the scapula to the humerus. Okay, and the scapula to different parts of the scapula. Like we have the coracoacromial ligament, which basically attaches two parts of the same bone. Okay, from the coracoid to the acromion. Even though it's attaching 2 points of the same bone, it is also very, very important. Okay, so we have those are the articular processes, and then we have the rest, which is the body of the scapula, which is laterally placed. Okay, now if we talk about the AO classification, 1-4 is the number given to scapula. 1-4A is the name given for the scapular process fractures. That is, we have three processes in the scapula. The first process is the coracoid fracture, the second process is the acromion, and the third process is the spine of the scapula. The spine of the scapula divides the scapula into the supraspinatus fossa, from which the supraspinatus muscle takes origin, and we have the infraspinatus inferior to the spine of the scapula. So 1-4A is the process fractures. The three processes being the coracoid process, the acromion process, and the spine. A414B are the body fractures. Now, body fractures are simple fractures which exits the body at 2 or less points, or complex fractures where it exits at 3 or more points. Again, this is irrespective. Most body fractures are treated non-operatively. Okay. Then we have 1-4F fractures, which are the glenoid fossa fractures. Glenoid fossa of these. So now when we're talking about the glenoid fossa fractures, okay, we have the anterior rim fractures. Now, why do we need to divide them into an anterior rim fracture and a posterior rim fracture? Because anterior rim fractures are easier to approach and fix anteriorly through the deltopectoral approach, whereas all the other fractures of the scapula require treatment through the posterior approach, which is either a modified or a classic Judith or a Brodsky approach. So all anterior partially articular fractures can be treated with a deltopectoral approach. And if there is a concomitant clavicular injury or a floating shoulder, both of them can be done through the same approach. Okay. Then you have the posterior rim fractures. Posterior rim fractures are easier to treat through the posterior approach. And then we have the short oblique glenoid fossa fractures, which can either be infraequatorial, equatorial, or supraequatorial. And most of them will have a piece of the glenoid neck involved as well. Okay. So what do we need to see from the X-ray or the CT scan? Okay, we need to look at the articular involvement if there is a incongruity or a step off. So this is about 20 to 25%. If there is incongruity or a step off, you need to go in and operate. We need to check for the glenopolar angle and the medialization of the glenoid fragment. I'll come to all of this. We have photos. And lastly, we need to look for the scapular body angulation. Okay. So biomechanically, fractures will lead to a Z-shaped deformity because of the pull of the different muscles which are present on the scapula. Indications are controversial, they are inconsistent, and the surgeons may not operate because of the complex anatomy, the approaches which are not very familiar, and the different fracture patterns. And as a result, there is not much evidence when we come to scapular fracture treatment decision making. Okay, so in our operative management, we have now only the pure operative management cases which we will be looking into, where there is no controversy. Of course, even a body fracture can be operated, but there is no strong evidence towards it. So now onwards, we are going to talk about the strong evidence pattern only. Okay, so scapular fractures were traditionally treated non-operatively with acceptable results, and operative treatment was only more recently prescribed, and it's a safe and effective surgery. And there are few studies which document the advantage of operative treatment in many injuries, especially when they are articular or having one of the specific indications for surgery. So why operate? Because problems can develop even after a displaced fracture of the scapula. What are these problems? They are most commonly related to altered shoulder girdle function. Not just these, even malunion of the scapula, along with malunion of the ribs, which are underneath, fractures which are present underneath, can lead to a grating sensation, which can be quite painful. Okay, so that is an impingement type of pain which can be seen.